Good morning, everyone, to this webinar. This is the first webinar of the Trust Stroke Consortium. So this is a series of webinars that will be performed and run by the whole consortium in a monthly way, just to promote the cross-sectional collaboration and cross-fertilization, because of even this high level of knowledge in this consortium and expertise. So I get my first slide, please, because I can see it. So the idea is to have this set of webinar. We suggest to have this open webinars just for the rest of the stroke community, and all physicians and non-physicians can join and learn more about artificial intelligence solutions and how to train algorithms for stroke prediction, in focus on stroke. So I don't have my first slide, so it's going a little bit slow. I'm not sure if I have to do something. Anything I can do, Stella? So the idea is, as you know, Trust Stroke is a consortium European-funded project in the framework of the Horizon Europe. So this is a consortium, a project based on the training of artificial intelligence solution for training algorithms in the safety way. So the data stays in the hospital, and it's the algorithms, the one who that travels from one hospital to other to improve the prediction of a stroke outcome. There is a first part that is a retrospective study, then we'll perform a proof of concept, and then the deployment of the algorithms in the final solution, which is going to be the platform NORA. So why is important this particular webinar? This particular webinar is clinical webinar is important because we need to share with all the partners what is the stroke pathway of care, which is very standardized from the pre-hospital setting, the hospitalization, and post-hospital care. All we need to know why we collect outcome data at different time points. So the endpoints for clinical trials and also for clinical research are well established. The most common outcome data is the ranking, but there are other outcome data that are relevant that give us a 360 degrees vision of the stroke disability. So that's why it's so important to know exactly in a clear way how is the stroke pathways. So I think there is a problem with the slides, Stella?
Yes, which one you want?
I try to pass the slides, but I can see them. So I'm going to the first one. I can see them.
You can see them in your screen.
No.
I see them.
Yes.
I'm not. I'm just talking.
But it's good. It was excellent. Perfect.
Yes,
so,
everyone can see them, but
is anything I can do in my screen, Stella, to see the slides?
no,
what's wrong? It's like thinking. The black screen thinking.
Maybe you can close the chat and.
I'll close the chat. The chat, you mean? The chat is closed. No. Nope.
No.
So in that case, let's move on to the first speaker. So we have today 3 speakers. So the 3 clinical representatives of the Trust Stroke Consortium. So Lemmens from Leuven, stroke neurologist from Leuven, will start the webinar, followed by my friend Pietro Caliandro from Gemelli in Rome, and finally myself. I will talk about the clinical outcomes. So let's get started, and I'm going to hand over to Robin. He seems to see the slides. Robin.
I can see the slides. Yes, thanks, Carlos. So I will talk a little bit about stroke epidemiology to give you some insights in the burden of stroke, talk about risk factors for developing stroke and how we can intervene with that, and then very shortly about the typical clinical and functional skills that we use in clinical practice. So if we look at the burden of stroke, and if we think about this for the future, there's some data showing that we will see an increased amount of patients being admitted for a stroke. And the reason for that is mainly because aging is one of the most important risk factors for stroke. And here you see some data for Europe, how the age of people will change over time. So this is maybe too small for you to see, but we start here in 1900 and we move to where we are now. And this is the life expectancy for people in various countries, looking at Italy and here, for instance, France and the United States. And you see that the life expectancy is increasing. And then if we think about the incidence of stroke in relation to age, you can also see that that clearly increases with age. So based on these kind of data, you can expect that if the population is aging and if the stroke incidence is mainly when people are at older age, you can immediately think that the amount of patients that we will see in our clinics will likely increase. Even if we are very effective in stroke prevention, just aging by itself will likely have an impact on the total amount of patients that we see. And that's also shown here. I'm showing you some Belgian statistics looking at the population and the distribution of the age. And so here you see that there are a lot of people now in Belgium who are aged between 40 and 69. And you see that this is shifting up. So this is from 2018. And so the amount of people that will reach that age where we know that there's an increased risk of stroke, you will see that that will increase. And so that will definitely relate to the burden of stroke. And that has already been shown. So here are some data also from a little bit from some time ago, where you see that the total amount of patients with cerebrovascular disease is increasing over time. And this is the curve that we are expecting. So you can clearly see that we will see many more of these patients. And that's even, as I mentioned, even if we are successful in our secondary prevention or even primary prevention. And so primary prevention means that we are effective in preventing any kind of cardiovascular disease, cerebrovascular disease. Secondary prevention relates to preventing a recurrent event in a patient who already has experienced a stroke. And so I think this here you can see that we are effective in our approach to prevent stroke. As you can see here, the incidence per age category is declining. I think there's an echo or something somewhere. If someone can do something about that. Anyway, if you see here, if we're looking at the incidence per age category, you see that that is declining over time. So 1990 to 2010. So you see that the incidence is declining. But immediately you also see that the total amount of patients that we see is dramatically increasing. So we see an increase with 1 million. And so although the incidence per age category is declining, we see that the total amount of patients that we see, that is still increasing. So the burden of stroke is increasing, although we are effective. Similarly, if we look now at mortality, which is shown here, this is also an illustration that our approaches in clinics indeed have benefits. So we see clearly that the mortality rates are declining here, as you can see in the numbers that are stated here or circled here with red. But you can also see that again, that the total amount of patients that have a fatal outcome after an event is still very high. So I think everything is the same illustration, that we see many more patients, and although we're effective, we see that the numbers are still very high. So it's not only a very important cause of mortality, but we also know that stroke is a leading cause of disability in adults. And here you see which kind of disabilities people experience. Some of those are very well visible, like patients who are experiencing hemiparesis, and so or aphasia, difficulty speaking, or experiencing functional deficits in their limbs. Others are not so very well visible, like cognitive deficits, and also many other psychological deficits that people experience after a stroke, which are not so visible maybe if you see those patients, but they do experience that. And so we will definitely come back to that later in the seminar. And that's also shown here, that we have different disability measures. We can look at functional disabilities in patients, but we can also look at depression, social disability, for instance, also here, poor subjective health. So it's a leading cause of disability, and you see that there's quite some heterogeneity in the disability that patients experience. So if we then take everything that I talked about briefly about epidemiology together, we think that now at the beginning of this century, approximately 1.1 million inhabitants of Europe have suffered a stroke, and the absolute number will increase. And by 2025, we think that that number may increase to 1.5 million. And so although age standardized rates of stroke mortality have decreased, and also incidence, if you look at age standardized rates, the absolute number will increase. And so the disability and also related deaths will increase very likely in Europe over the next years. And this means that the overall burden of stroke will be increasing. So therefore, I think this really illustrates the importance of this particular project. So I was also asked to talk a little bit shortly about risk factors and also about stroke etiology. So the typical risk factors that we know for any kind of vascular disease are also prominent for patients who experience a stroke. So hypertension is one of the most important risk factors. Aging, which is a risk factor which cannot be modifiable, and I showed you already what the effect of aging is on the incidence of stroke. Not a sufficient amount of physical exercise, as you can see in the right top corner, and then everything related to alcohol consumption or smoking and an unhealthy diet. So this is just a few of those very important risk factors that we can tackle. And this relates both to primary prevention and secondary prevention. So again, primary prevention is preventing the first stroke event. But if patients are admitted at stroke units, we talk about risk factors and try to see whether we can reduce those risk factors in order to prevent a recurrent event. So what do we do in primary and secondary prevention? So we have to treat hypertension, we have to treat hypercholesterolemia, we have to convince people and assist them in trying to quit smoking, increase their physical activities, and to also stimulate them to eat healthy and to prevent obesity. So those ones are related again to primary and secondary prevention. The second here, initiate antithrombotic agents. That's mainly related to secondary stroke prevention. And so we know that we can be very effective if we can optimally treat those risk factors. We can reduce stroke risks, and that's illustrated in this particular graph. I will not show you graphs for all these particular risk factors. So I will not show you this for hypertension or diabetes or any other risk factors. But here I'm just showing you if we indeed are capable of reducing, for instance, cholesterol levels. So LDL is what we typically call, of course, the bad cholesterol. And if we treat those with statins, which are very effective in lipid lowering, you can see that if you reduce if you reduce the LDL, if you reduce cholesterol, which is shown on the x-axis, you are very effective in preventing vascular events. And so the more we reduce the cholesterol, the lower the risk of stroke, and that's shown by various studies. And I could show you similar trials as it relates to optimal treating diabetes and optimal treatment of hypertension. So if we are successful in managing all those risk factors, and that again also relates to this particular project. So if we can identify the risk factors in patients and try to manage them most optimally and initiate treatment, we can reduce the risk that patients experience after the first event with almost 80%, as shown in this particular very large cohort study, which was published in 2007. So here you see that this is typically what we tell our patients in our stroke units. We talk about the fact that since they had a stroke, they have now an increased risk of another stroke. So previous stroke is an independent risk factor for a future event. However, if we are able to manage all the risk factors identified and reduce those, we can actually decrease that increased risk by 80%. So secondary preventive management is very effective in preventing a recurrent event. And of course, we just have to make sure that we can identify the risk factors and try to manage them most optimally. And again, that relates to this particular project. So we talk to our patients on the stroke unit. We talk about risk factors and we talk about causes or etiology for stroke, which are two different things. So risk factors are related to risk factors for any kind of vascular disease, and in particular for stroke. And so risk factors increase. Risk factors increase. Basically risk of a stroke event. But smoking does not give you a stroke. Smoking increases your risk. Etiology means that we try to identify which reason we can identify, which was actually responsible for stroke. And so, for instance, here you see large artery atherosclerosis. So this is large vessel disease. So smoking and hypertension can contribute to atherosclerosis, and an atherosclerosis can then cause a stroke. So that's a difference between risk factors and stroke etiology. And so that's what we typically do in the stroke unit. We try to identify the cause of stroke and not only the risk factors. And since if we can identify the cause of stroke, we can then have a particular management focused on that particular etiology. So we have small vessel disease, which is typically related to very small subcortical strokes. And so, for instance, risk factors such as hypertension and diabetes are typically associated with small vessel disease. We have large artery atherosclerosis. And so atherosclerosis is mainly known, for instance, for coronary artery disease, which is mainly caused by atherosclerosis, but in stroke, this is only in 25% of patients. We have cardioembolic here, it says 20%, but typically this is a little bit larger. And this relates mainly to atrial fibrillation, which is a rhythm disorder, arrhythmia of the heart, which can be responsible of clot formation in the heart, which can then be distributed towards the brain. Here, I won't talk about this small category of 5%. This is other or rare disorders. And then 1 in 4 patients, we cannot really identify the cause of stroke, although we have performed a lot of examinations and tried to identify the exact reason what caused the stroke. So again, if we look at reasons for stroke, there's a difference between risk factors, which can contribute to causes which are identified here. And so stroke subtypes are really related to trying to identify the exact cause. So then finally, I want to talk about the skills that we're typically using in stroke patients. And this is also important because you will see this very often returning in publications, but also in seminars or lectures, where people will talk about stroke severity and stroke outcome measurements. So typically in clinic, we measure stroke severity by looking at the NIHSS stroke scale. And this is a scale where we try to have some kind of idea about stroke severity. So the scoring ranges from 0 to 42. And here you see, so 0 means that there's no stroke symptoms. Between 1 and 4, we typically state that this is a minor stroke. Between 5 and 15 is a moderate stroke. And then if we go higher, mainly these are severe strokes. And this here you see the typical clinical examinations that we're performing when trying to obtain the NIH in stroke patients. And so what I typically tell my residents, this is a very short examination of a full neurological examination. So it's just a short version of a full neurological examination. And the reason for that is that we do this rather short because time is brain is a common sense, a sentence that we use when treating stroke patients. We want to be as quickly as possible to try and solve the problem when patients are admitted. And so there's no time for a full neurological examination. But if we do this rather quickly by this 11 scale NIHSS, in a very short time interval, we try to get a sufficient amount of information about how severe the patient is affected. So we look at level of consciousness, we try to see their orientation, and we look at speech and language, as you can see here. We look at visual fields, we look at facial movement, we look at whether there's paresis in the arms and legs, we look at ataxia, sensory symptoms, dysarthria, which is also related to speech and extinction. So I won't be going into too many details about this. these neurological terms, but I will just, so in summary, it's a very short examination that we can perform very quickly in our stroke patients to have some kind of idea about the neurological deficits that the patients are experiencing when they're admitted at the ER. And so NIHSS is very good to assess stroke severity. It's not the most optimal scale to measure outcome. And so for outcome, which is typically assessed in stroke patients at 90 days, we use a very functional scale, which is the modified ranking scale. This is mainly focused in how the patient is indeed doing functionally, as you can see here in the title. So this is an ordinal scale, which ranges from 0 to 6, and 0 means that the patient does not. So this is for men on top and women on the bottom, as you can see here. So we look from 0 to 6. 0 means that there are no symptoms, and 6 means the most is a fatal outcome of death. And then anything in between, as you can see here, is increasing disability. And so what we typically define as excellent outcome in stroke patients is a modified ranking 0 to 1. And so good outcome is still modified ranking 0 to 2. And so we will talk about this later in the seminar to talk about which kind of other measurements may be more optimal for measuring outcomes. And this is very much focused on functional outcome. So if you would ask the patient that he or she can still do everything the same as before the stroke, we would say, well, that's a modified ranking of 0. But if that patient is very depressed after stroke, that's not really captured by the modified ranking so clearly. And so that is why we are also focusing in this particular program, a project on other outcome measurements to have a better full examination of how a patient is doing. And so that will become more apparent when we go over this seminar. And well, I will now give the word to Pietro, who's going to talk about the next topic.
Thank you, Robin. So now we will speak about 3 different aspects. We will try to define the acute path of stroke management, which is, as Robin said, very strictly standardized and very well defined by the international guidelines. So first of all, what about the path in the acute phase? You have to consider that in the emergency room we see different kind of patients. So the first need is to identify patients who are coming to the emergency department with an hypothetical stroke picture. So we need the physician, the neurologist of the stroke team need to be advised that a patient is coming with a probable stroke. So there is a stroke code, a red stroke code, which identify each patient coming with a suspected stroke. This slide is to show you all the things I will speak about are very focused on the international guidelines, but at the meantime, I speak about also our experience in Gemelli, which I think is quite close to the experience in Leuven and Vall. When the patient arrives in the emergency department, the stroke neurology know that a stroke patient is coming. The first step is to perform a very fast but a deep clinical evaluation, and the main clinical tool is the NIHSS score, which Robin described you. And of course, we need to support the vital functions of the patient and perform some blood exams. This first step is very important to define the clinical severity of patient, and soon after, in a very fast way, we need to define the situation of brain. So we need to perform some exams, some neuroradiological exam, brain CT, with angio CT, and sometimes in particular situation perfusion CT. What is brain CT? Is an exam which mainly helps us to define two different kind of stroke. Stroke caused by ischemia and a stroke caused by hemorrhage. We are focusing on ischemia, and about this kind of patients, we need to identify those patients in which ischemia is due to the occlusion of a large artery. That's why angio-CT scan is very important, because angio-CT scan is able to identify the large vessel which is causing an ischemia of the brain, and therefore the clinical picture, the clinical severity, which we use to call stroke. Perfusion CT is an extension of this kind of neurological exams, which is very important in defining time of onset of symptoms, and mainly it's very, very important in distinguish between the part of ischemic area which we cannot able to save with a reperfusion technique, and the part of the brain with ischemia which we can help to restore. Why we can help to restore an ischemic brain area? Mainly with two different approach: fibrinolysis and mechanical thrombectomy. Fibrinolysis is the infusion of a drug with the aim to provoke the lysis of the clot, which is closing a vessel. Fibrinolysis may be performed when a lacunar stroke is causing the clinical picture, when a large artery is closed, while mechanical thrombectomy is a mechanical thrombectomy. So it's a procedure which we perform by a catheter. We're going close to the clot, which is closing a large artery, and we try to take away the clot, closing the vessel. Of course, mechanical thrombectomy is not able to open very, very little arteries, which cause lacunar ischemic stroke. Here I report this score, the TG score. The TG score, which we can summarize in three different scores. It's a score which describe how we were clever in determining the reperfusion of the large artery occlusion. TG score goes from 0 to 3, where 0 is no reperfusion after the procedure of mechanical thrombectomy. 1 is a not functional reperfusion. 2 with 3 different subscores, but 2 score means that there is a reperfusion, there is a functional reperfusion with different degrees of functional reperfusion, and 3 when we get a complete reperfusion of the vessel. But this slide is just to show you that both fibrinolysis and mechanical thrombectomy are very well standardized. The technical are very well described, and the cases when to apply fibrinolysis and thrombectomy singularly or in combination are very well described, and the level of evidence is very, very high. So what I'd like to show you with this slide is that the standardization of the acute phase of stroke is very well standardized and very well fixed. But we have some particular cases too. On the left side here, this is the typical angio-CT scan. This part is the right hemisphere, this is the left hemisphere, and as you see, we have a vessel, the median artery here on the right side, and here on the left side. Looking at the vessel on the left side of the brain, we may see that here there is a stop of the vessel. This white area is the part of the vessel where the blood is flowing, and after here is the area where the blood is stopped. This is another vessel image. This is an angiography. The angiography is the typical image that we have when we are performing a mechanical thrombectomy. And here you see the same vessel which is closed, and on the right side of the screen you may see the same vessel which is opened, and you may see the blood flowing again in the vessel. So we have treated a patient following the guidelines, but this is the results. As you may see, this area in the left hemisphere is this black area is the area which we may see after mechanical thrombectomy sometimes. And this is an ischemic area causing right hemiplegia of the patient and the global aphasia. Global aphasia is a particular clinical situation in which the patient is not able to speak and is not able to understand what someone is telling. Why? I'm sorry. Why this is important? Because our project is the very have the very crucial aim to predict all those cases which, well treated following the guidelines, may have a not very good outcome. And of course, we need to understand why, and we need to understand how we can improve this situation. After the fibrinolysis or mechanical thrombectomy, there is a very important part of the acute path of stroke management. The patient goes in a stroke unit where we perform all those exams that Robin explained before, trying to understand the cause of the stroke in that particular patient. That's very important because according to the cause which determined the stroke, we have to decide the best secondary prevention in each patient. So, summing up, we may say that there is a path in the acute phase. The patient arrives in the emergency department. After there is the evaluation of the stroke neurologist, and in this moment, the NIH score is very important because NIH score defines the clinical severity of the patients. The patient performs brain angio CT, and again, the stroke neurology decides if that particular patient may perform fibrinolysis, mechanical thrombectomy, or no reperfusion technique, because we have also this kind of situation. After reperfusion or the decision to not reperfuse the patient goes in an intensive care unit, stroke unit, or non-intensive department, where all the exams with the aim to identify the cause of stroke are performed. And after, the patient may be discharged at home or in a rehabilitation department if there is a clinical severity which needed to be rehabilitated. When the patient is discharged, we have the second phase, the chronic phase of the path of stroke patients. I have to say that the chronic phase is a little bit less standardized when we compare it with the very acute phase of the management of the patients. But we may sum up that the main steps in this phase are the rehabilitation. The rehabilitation, of course, is important when there is a disability, and stroke is one of the most frequent cause of disability. The patient may be discharged at home with the indication to perform rehabilitation with in domiciliary setting, and this part is very important because Nora may help us in follow this patient at home. And we need to perform a clinical follow-up in the hospital, where we need to evaluate the clinical evolution of the patients and to optimize the therapies for secondary prevention. Speaking about trust stroke, we have some crucial clinical endpoints that we need to predict, but this step, our first step is the prediction of the clinical response to the acute reperfusion treatment, so fibrinolysis and mechanical thrombectomy. And of course, to predict the severity of stroke at the moment of discharge from the acute phase. The second step is to predict the probability of early supported discharge. That's very important. Which kind of patients we will be able to discharge within 1 week after stroke. Speaking about disability, of course, we need to understand which patient will have a poor mobility after the acute phase in terms of ranking, and we will see in terms of PROMS and PREMS. What is the probability of a unplanned hospital readmission at 30 days, and what is the personalized risk of stroke recurrence at 3 and 12 months. These are the CHEP of our trust stroke, but how we merge this CHEP and the path we have described. So looking at the path described, we may say that CHEP1, the prediction of response to reperfusion, and NIH at discharge, we need to predict it when the patient arrives in the emergency department before performing fibrinolysis and mechanical thrombectomy. About NIH at discharge, we may refine our prediction after having performed fibrinolysis or mechanical thrombectomy, because the clinical picture may be strongly conditioned by the efficiency of the reperfusion technique. And also in this step, we may predict early supported discharge. So what is the probability of a patient to be discharged within 1 week? Of course, this CHEP may be strongly conditioned by the possibility to perform fibrinolysis or mechanical thrombectomy, or if a patient performed no reperfusion, probably this delay will be longer. What about the last 3 CHEPs? These CHEPs probably are to predict at the moment of discharge. So at the moment of discharge, we need to predict for each patient the probability of poor long-term outcomes in terms of modified ranking scale, PROMS and PREMS. We need to predict the readmission at the hospital, not only for stroke, but for any cause of clinical problems, and we need to predict recurrence. So at discharge, we need to predict recurrence, stroke recurrence at 3 months. We could try to predict stroke recurrence at 12 months, but this prediction could be
We can't hear you, Pietro.
Pietro, you're muted. Muted.
I can't see him either.
He's coming.
No.
He's right here.
Have you lost
Yes.
me? I don't know why.
Yes.
Okay.
You're back.
I don't know when you were with. So I was telling that about the 3 last CHEPs, we may predict them at discharge. And about CHEP 5, stroke recurrence, we need to predict stroke recurrence at the moment of discharge. We should predict stroke recurrence within 3 months. And after 3 months, we need to predict stroke recurrence at 12 months. Thank you.
So thank you very much, Robin and Pietro. So I will continue with the last part of the seminar. It's about the impact of clinical outcomes. Traditionally, we collect the modified ranking scale score as the benchmark way to assess clinical outcome in stroke patients. So it's a very bad scale, let's say, because it's relying basically on motor deficit. So, but other aspects of disability are not really captured by the NIH stroke scale score, including fatigue, sleep disorders, visual problems, and cognitive difficulties that can be easily captured by other metrics. So the NIH stroke scale score that traditionally is a consensus that is collected at 3 months. This consensus comes from clinical trials, but it's also implemented in clinical routine. So it's under discussion, and we need to add more scales, more accurate scale, and also about the timing. If the timing of collecting these scales is the same and fixed at 3 months for all strokes, maybe for minor strokes and TIAs early on, like 1 month or 3 weeks after a stroke, and for more severe stroke that they need more time to recover, should be at 6 months or even later on. So this is an example in this slide how the definition of disabling stroke is changing. In particular for those patients that apparently they are independent at 3 months, like patients with TIA and minor strokes. You can see how the burden of disability is relatively high in this patient, despite being qualified as independent by the ranking score. So we performed a study, like a year ago, based on the data collection by the NORA application. So we collect systematically outcome data, the ranking, but also the PROMS and PREMS. What are the PROMS? The PROMS are the so-called patient-reported outcomes. The thing is that using the modified ranking scale score, we just collect the data from the physician or healthcare professional perspective. We score the patient. The PROMS is the patient score him or herself, or the caregiver is scoring. So is it what is the information that is relevant from the patient perspective? That's why it's patient-reported outcomes. And we also have scales for patient-reported experience. So it tells us, so what is the patient journey impact on the patient? If the patient feels comfortable with this patient journey he just passed. So in this study, you can see how collecting this information, the capture information about mental status, fatigue, and also depression, you can see that how in patients are qualified as independent at 3 months with TIA and minor strokes, so they have a ranking 0 to 1. It means independent for daily living activities, like Robin just mentioned. So these patients, up to 26% were depressed at 3 months, and up to 36% were unable to return to work within a year after stroke. This is a problem. This is a problem that the ranking is unable to capture. So, and also the rate of cognitive decline is high, up to 25% of patients with a TIA minor strokes. Those are the success of thrombolysis, for instance, of reperfusion. These are the patients that are really good at 3 months. So these patients, so up to 1/4, it means 25% have signs of dementia at 1 year after stroke. So this is something we need to look at, and this is why we are having this kind of building up these models of artificial intelligence to predict those patients who are at risk of clinical decline after a successful reperfusion, for instance, or after a TIA and minor stroke. So this is the way and the time points we collect the outcome data. The PROMS, the PROMIS 10 is the more typically used. It's a benchmark scale, and the HATS for depression and anxiety. For the PREMS, we use the PICA, which is very focused on treatment adherence and pharmacological adherence. But there are others that we need this. I think in this consortium, we have the huge opportunity to customize and create focus groups to create our own PREMS. It means from the patient perspective, what is for them the quality of service and the experience in this entire process of care. And the CROMS is the clinical reported outcomes. It's from the physician or healthcare professional perspective, what we score the patient as independent. This is a traditional way to assess patients. And as you can see, we evaluate these scales at day 7, at day 30, and day 90 using the hybrid application, NORA. That is there is a case manager that's in contact with the patients before the patient is discharged. So the case manager introduces her or himself to the patient. So they establish the connection. Then the patient is discharged, and this system encourages patients to report the patient-reported outcomes and patient-reported experience. So it's for a long time, it's been a problem to collect this data in a very accurate way with rates of no more than 40% of fulfill these questionnaires. So now we have rates higher than 80% in other projects, but harmonics, that we can collect this data at day 7, day 30, and accurately at day 90. So this is an example of Neuralytics, is the dashboard that is uploaded almost weekly. So this is another project with this harmonics, and this is an example that we are going to do also in trusted stroke in the consortium of the 3 centers, so we can compare the patients that are included into the study in the prospective part. And also, as you can see, this is the left-hand side of the screen. You can see the scale, the quality of life, the HATS means the hospital anxiety and depression scale, the PROMIS, there is a PROMIS physical and PROMIS mental, also that evaluate respectively the mental problem, the physical problems and mental problems, the fatigue scale. Fatigue is very important. So we think that fatigue is okay, it's something that you supposed to happen after a stroke. No, it can be very disabling. It's one of the main causes why patients that are independent at 3 months never work go back to work. So the Morinsky Green is on a scale of treatment adherence, so we can measure the level of treatment adherence, pharmacological, not only pharmacological treatment adherence, but also other interventions and the ranking. As you can see here, how across all the centers we can compare and benchmark the rate of fulfillment of the PROMIS. So it's very efficient. So this information is in the system, then it's transferred to the electronic medical records to be stored there and then collected. This is the way we plan to collect this information in trust stroke in a very reliable way. So you can see this is the level of poor PROMIS. This is around for HAT is 30% anxiety, 15% depression in the environment of harmonics. So you can see the mental impairment is about 42%. So minimal signs of mental impairment are detected by this scale, and the PROMS, the physical, of course, depends on the case mix. If you have more disabling stroke, more the PROMS physical will be more affected. The WPAI is related to the cost at 1 year. As you can see in the right side hand of the screen, the ranking score at admission, at discharge, also 30 days and 30 days and 90 days. And below that, you can see the stratification according to stroke severity. So 0 to 5 means minor stroke. 6 to 14 means moderate stroke, and more than 14 severe stroke. And as you can see, the blue, light blue bars represent the level of independency at daily living activities. There is a clear correlation between the baseline NIHSS stroke scale score on admission and the outcome. It's easy to stratify and categorize patients according to stroke severity and predict. It's the most powerful predictor of stroke outcome is stroke severity on admission. And that's it. And thank you very much for your attention. So there is I think during this almost 1 hour of webinar, we give you an overview of the epidemiology, risk factors, acute treatment, acute management, also clinical endpoints, and the way we try to collect a more broad spectrum of clinical outcomes, only relying on the motor deficit, but also other functions, including the cognitive, the emotional functions that are really impact the patient outcome and quality of life. So now we have some questions. So I'm just checking the questions in the chat. There are a bunch of them. So let's get started with Carolina. Carolina asked about what are the measures that Vall, Gemelli, and Leuven hospitals are adopting nowadays to motivate patients who have had a first episode of stroke to manage and reduce the risk of factors and have led to the cause of stroke. So maybe you can take this one. So at least in Vall, we use NORA. Since I just mentioned this hybrid solution that encourage patients to control risk factors. So we demonstrate in a paper published 3 years ago in stroke how using this method, this approach using NORA, we increase the level of risk factor controls from 42% to 84%. Nowadays, it's 84% in the environment of harmonics, so at a regional level, so it can be done. And also why this works, because there is a case manager. There is a person behind the application. It's not just an APP. So you have a person behind that is customizing patient needs. So there is a chat for any question that the patient have. Also the modules for education that are very useful for patients are very customized according to the pathology. If the patient has a hemorrhagic stroke, have the specific contents for hemorrhagic stroke. You have you are hypertensive also, and it encourages pretty much the treatment adherence and also risk factor control. And now you, Robin, or Pietro will add on this.
Yeah, so when we start risk factor management, I think in the stroke unit, where we have various brochures depending on the risk factors. I mean, we have brochures where we give general information about risk factors. And then indeed we talk about the exact management. So for instance, for quitting smoking, we have a strategy developed in the hospital where we can initiate this on the stroke unit, and they have follow-up consultation in the outpatient clinic, which is related to quitting smoking, for instance. We have a dietitian for if it's related to diabetes, and that particular patient will that particular person will follow up the patient and contact them by phone. In general, also we have a rather well established GP system where patients are followed up with their GP for risk factor management. So it's several people, but it starts, I think, with explaining to patients what their risk factor profile is and to give them information about this. So we develop brochures for that to explain this in an easy way, because typically, of course, if you're admitted at a stroke unit and there's this talk by your physician about risk factors, you go home and you forget like 80%. And I mean, all of us would forget 80%. So if you have that in a brochure where you can read about it thereafter, I think that's also of importance.
Yes, our approach is quite similar to the one Robin described. I mean, we give information to the patients about how important is the risk control, and we have a service after discharge where we follow patients periodically, each 3 months generally. But not all patients discharged from stroke unit are followed up. So we follow up in our hospital only a few percentage of patients who needs a particular attention for some reasons, but we have not a huge follow-up of all patients. Here in Italy, all patients after a stroke are followed by his her own familiar physician, and when it's necessary because of some new situation, they can contact us and come for an ambulatory visit. But we follow only a percentage of patients discharged by the stroke unit. So in this view, NORA could be a good opportunity to implement the possibility to follow up all patients when they stay at home and to get feedback from them, also if we don't see them in the hospital.
Thanks. So the next couple of questions come from Draghi Kocher. It's about it's about CT scan. Does every patient gets CT scanning? If not, what is the decision path to send a patient to the CT scanning? What proportion approximately of the retrospective patient have a CT scan? This is the easy one. And the next one is how much the analysis of the CT scan is correlated with the NIH stroke skill score. This is a good one. Whether one can use the scan to assess the NIH with a high confidence. Maybe both of you, Robin and Pietro.
Robin?
Well, so I think everybody gets the CT scan. There's some maybe get MRI, but I would say like in general, most will get CT. And so if you look in the retrospective patients, will most, like over 95% will have acute CT. Whether or not this correlates with NIHSS depends a little bit at the time frame that patients are presenting. If they present acutely, typically, if they really present, this is really acute, there's not so much to be seen, and not with the naked eye on the CT. So you can debate whether AI may be better in identifying early changes on CT. That is possible. That's a project by itself, I would say. If they come in later, you will see some hypodensities, as Pietro was describing on CT scans. And so there, of course, there is an association between the volume of the stroke lesion and in relation with the NIHSS. So whether that's high confidence, I would not say that to be high. And especially if you're looking in the early time window, I think on CT, there's a lot missed. And so we didn't talk so much about skills that we're using related to imaging. And so, for instance, we have the aspects, which is also an ordinal scale from 0 to 10, which is scoring abnormal regions, mainly focused on one part of the brain where most strokes occur. And also there we see that there is a relation between that scoring, but there's a lot of issues with that because there's a lot of variability when looking at that scoring. So I would not be too over optimistic about the relationship with the NIHSS and then the retrospective assessment of the CT scans in this cohort.
Yeah, fully agree.
I totally agree. Just to one thing to comment about CT scan. All patients perform CT scan in the very acute phase of stroke, and after fibrinolysis or mechanical thrombectomy, they generally perform another CT scan, which allow us to see the lesion. And some of them perform MRI. MRI is not so common in the very acute phase when the patient arrives in the emergency department. Just only a few percentage of patients perform MRI. And I totally agree that the neuroradiological images can be part of the prediction, but there is a not strict relationship between MRI or CT scan lesion and the clinical severity.
Good, excellent. So the next question is from Sanas. This is very straightforward. So the NIH stroke scale is available for patients in the acute phase at all 3 patients. The answer is clearly yes. It's the most important quality metric that we have in all medical histories in stroke patients is the NIH. You can miss even the name of the patient, but never the NIH stroke scale score is always there. So it's important, it's relevant, not only on admission, but also on follow-up, is the way we establish if the patient is stable or if the patient experiences clinical deterioration, especially the baseline 24 hours and sometimes discharge, but baseline 24 hours is pretty standard. So the next question is from Carmo Requejo. Do you know the percentage of patients that were already under the care of a related condition, this is, before having a stroke? I think you refer to patients with previous disability or a previous condition, previous stroke, so before. So we have a medical history, so we collect this information from the medical history and also the previous ranking. That is relevant. to have the previous ranking, because help us for the decision making. That if patient has a previous ranking that is 4 more, 3, 4, so you have to tailor the decision of whether the patient goes for mechanical thrombectomy, a very aggressive measure. So if the patient is demented or in an institution for a long time, probably is not the best patient. So the information about previous condition is there in the medical history, in the retrospective database, and it's going to be also in the prospective one. The next one, what is the percent of patients that end up with cognitive decline? I already mentioned, so it's difficult to establish accurately in all stroke patients because it's difficult to assess cognitive decline in severe stroke patients with a ranking 4 or 5. Of course, they have aphasia for sure, they have a cognitive decline, but what we know is from studies in TIA minor stroke that up to 25% have signs of cognitive decline 1 year after stroke. So having a TIA is not a benign condition. It's up to 1/4 of them will have signs of cognitive decline, and this is something we need to work on to identify the predictors for cognitive decline in this population. I don't know if you want to add something here.
Yeah, I just want to put it on the chat, maybe, if possible. So there's a good article about the cognitive deficits after stroke published half a year ago, and basically describing which kind of different cognitive deficits occur, and also that we don't have great insights in the exact percentages. There's a lot of variation in the different studies reporting on that, and this can be related to the skills used or the incomplete assessment of cognitive deficits. So definitely there's a great need to have a better insights in that. Yeah, that's the only thing I wanted to add, Carlos.
So the next question comes from Luigi Serio. Minor disabling strokes appear to have better functional outcome, but do minor disabling stroke correspond to a reduced risk of recurrence? So it means that the lower the NIHSS stroke scale, the lower the rate of recurrence. With respect to severely disabling stroke, what features shall be considered part of the given therapy? Pietro?
Also, patients with minor stroke may have a high percentage of recurrence. It depends on the overall clinical situation. How to say, if, for example, a patient has atrial fibrillation, which is a particular arrhythmia, and he has got a minor stroke, the possibility to have a recurrence also in the future, despite the secondary prevention, may be important. So I don't think there is a strict correlation between the severity of a clinical picture at discharge and the probability of stroke recurrence in the future.
And the next question is from Monica Nicoli. What are the main indicators, measures that are collected by all hospitals in the consortiums, and what are those are available only in a subset data set? So this is something we are working on it now. So we know what are the usual suspects, variables that are there, like the NIHSS skill score, the ranking for sure. So the length of stay, the NIHSS discharge, blood pressure, and treatments, and so on. These variables are structured data in the data sets for sure. But also part of this project is to harmonize and standardize the data sets. So this is part of the project, and for the retrospective part to harmonize the data, and for the prospective part, so how to identify those variables and indicators and measures, including PROMS and PREMS, and the time point, exactly time point that agree with the time points for data collection. This is something we need to explore actually in TRUST stroke. So the next one is from Tanushi from Star. How is the PROM data collected stored? A standard questionnaire that form part of the electronic medical record directly or similar structured databases. So I can take this one. So the PROM is a standardized questionnaire. This is in our experience, we collect this information through NORA. So it's very straightforward by the application. The patient just click the points. As this, you can analyze then the total score and separate the items also can be analyzed. And we are in the process by other project and also by trust stroke will integrate this in the electronic medical record. This information doesn't belong into the application, goes straight to the electronic medical record, can be explored there, and then is transferred to the for the trading of algorithms. So there is another one. How does patient participation answering PROMS and PREMS vary by age? Good question. Good question. In the stroke patients, so the answers are not coming not only from the patient, also from the caregiver. So this is duality that you have to take into account. So sometimes the patient, due to the disability, because he is aphasic or have a paresis or motor dysfunction, is not able to answer or to collaborate in reporting the PROMS and PREMS. And in many cases, is the caregiver. The caregiver, the one that provide actually the data. Actually, in harmonics, up to 50% of the response are from the caregivers and 50% for the patients. And the older the patient, the higher this proportion. The younger the patient, the more collaboration. Also, it's related to the disability. For patients with minor stroke and TIA, they are more able to respond than patients with more severe strokes. So let's go to the final question. So because the time ran out already. Do we expect PROMS and PREMS, patient reported out, and CROMS will be merged, analyzed jointly to evaluate the stroke risk? So more than evaluating the stroke risk, I think is the endpoint. So this is the risk of having a poor outcome based on CROMS and PROMS. So this is the endpoint. This is what we have to look at. So we need to explore the risk factors before that, before patients is discharged, and we can we'll be able to modify the natural history in terms of recurrence and disability in these patients. I don't know if you, Robin or Pietro, would add anything.
No, I completely agree. These are outcome measurements and not to evaluate stroke risk. And I think there are other parameters probably that we would be looking for to evaluate stroke risk or stroke recurrence risk. Yeah.
Completely agree.
So, well, thank you very much. First of all, the speakers, Robin and Pietro, thank you very much. Very clear presentations, and also the audience very active in the questions. I don't know if we have 10 or more questions. So I hope we successfully answer all of them. So this is the first of our seminars, webinars for the Trust Stroke Project on clinical outcomes and the stroke path of care. There will be more in the future. We'll restart these sessions in September in a monthly way. The cell will have a dedicated webinar just for explaining the federated learning, the EuroCAD, the algorithms, NACA, the design, the patient approach, and how we can improve the interface of patients and applications and so on. So once again, thank you very much for attending this webinar, and see you soon in September in the next webinar.
Thanks. Bye-bye.
Bye.
Bye. Thank you. Bye.